Welcome back to the 2019 CGA podcast series brought to you by the Education Committee. Today's episode is the sixth and final in our series, which focuses on multidisciplinary, patient-centered approach to management of familial adenomatous polyposis. My name is Alana Levinson. I'm a genetic counselor at New York Presbyterian Hospital, Columbia University Medical Center, and I will be your host today. Before we start, I'd like to remind you that the content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. During today's podcast, I will be speaking with Kristin Zajo, a genetic counselor at Nationwide Children's Hospital in Columbus, Ohio. Our focus is on children and young adults with FAP, and specifically in regards to management and transitioning from pediatric to adult care. Kristin, thank you for speaking with us today. One of the things that distinguishes FAP from other inherited cancer syndromes is that symptoms can occur during childhood, and therefore genetic testing and surveillance often start at a young age. Kristin, working at a children's hospital, you specialize in pediatric GI cancers. Would you tell us a little about your role at NCH and specifically your work with children and families with FAP?
Yes, thank you for having me. I started working with the GI clinic here at Nationwide Children's Hospital in 2015 when we recognized that there was really an increasing demand for genetic counseling services, specifically in that clinic. So at the beginning, we started off seeing a few patients a month with FAP and other polyp predisposition syndromes. And then once word started getting out to local providers, we started to see an influx of new patients and families, especially from our adult centers where they had been providing excellent care to adult family members, but had fewer resources specific to pediatric care. So we now have a weekly multidisciplinary clinic that includes myself, a GI physician who's an expert in pediatric polyp predisposition syndromes like FAP, and a pediatric psychologist. The team approach has been great because it really helps address all aspects of being diagnosed and treated with a lifelong disease, especially for kids at an age in which a patient is often too young to fully grasp what that diagnosis means. And a big part of my role in clinic, aside from facilitating the genetic testing portion, is to work with families to help them adjust to a diagnosis and really identify resources to help them navigate life with FAP.
It sounds like you've put together a great team and identified a niche that really needs to be addressed. Could you describe some of the types of issues that the children and their families face when they're adjusting to a diagnosis of FAP?
Yeah, the good news is that we found that many children and families adjust really well to this diagnosis, but there are certainly a subset of individuals who experience more distress. And a lot of that distress seems to be centered around this fear of the unknown or what might be coming in the future. So, for example, if a child is the first person in the family to be diagnosed with FAP, there can be a lot of anxiety and worry about the future, especially not knowing if a cancer will develop and what these screenings are really going to be like for them. And just anecdotally, in our clinic, children who have a parent with this condition who's done relatively well tend to also do well. And we think it's probably just due to this prior knowledge about the condition and kind of understanding what that surveillance will look like. So it really removes that element of the unknown. And then some patients and families will benefit from working with mental health providers like a pediatric psychologist to adjust to FAP, both at that initial time of diagnosis and then longer term. So it's been critical that we've had this pediatric psychologist on our team who can either see these patients more on an outpatient basis or help connect them to resources that are closer to home for them to get those services when they need them. The other thing we've noticed is coming into the visit with inaccurate information can be a huge barrier to adjustment. So we'll see families come in with preconceived ideas about FAP that might not be fully correct, a lot of times coming from things like internet searches or online message boards. So what we found is that families benefit a lot from just receiving reputable information from that very first visit and getting some relief from just learning about a plan to keep them healthy long term and kind of correcting any misconceptions about FAP that they might have heard along the way. Another big area of adjustment issues comes from body image and physical concerns, so especially related to things like surgeries, perhaps telling a partner about the condition is something that we'll see in some of our older patients, and that can really impact their overall coping even after that initial adjustment to the diagnosis. And then from a family standpoint, I think the other big issue we see in adjusting to the diagnosis is just parental guilt about passing the condition on to their children. So at times we've had parents of our patients who benefit from managing this guilt through working with their own psychosocial provider, so getting counseling services themselves to allow them to help adjust to their child's diagnosis so that they can also help their child adjust as well.
So it's interesting. So it seems that a lot of the care in at least the initial stages of diagnosis are really more focused around psychosocial issues and adjusting to that. And I can see how having a psychologist on your team is really beneficial.
Absolutely.
So I'd like to switch gears now and focus on medical management for children with FAP. NCCN guidelines for hepatoblastoma screening have shifted in the past few years. Previous recommendations included periodic liver palpation, abdominal ultrasound, and serum AFP measurement for children ages 0 to 5. Current NCCN guidelines, however, now state that there are no defined recommendations, but that screening could be considered. Kristin, could you tell us about how your group at NCH approaches hepatoblastoma screening?
Our approach has been to explain, just as you said, that there's no defined recommendations for screening, but certainly it could be something that's considered in some of our younger patients. So we typically just explain that the recommendations for that serum AFP testing and the abdominal ultrasound in FAP patients really come from the guidelines developed for another genetic condition called Beckwith-Wiedemann syndrome, where the incidence of hepatoblastoma is a little bit higher overall. So we do have families who come in with a known history of FAP, and they'll bring their infants to us because they know about this hepatoblastoma risk and they really want the screening. But then we have other families who come in with a strong family history and no one's ever had hepatoblastoma in the family, so they might feel a little bit less inclined to pursue the screening in their child. So really, we've just tried to present the available evidence about hepatoblastoma risk and then just kind of walk through the pros and cons of that screening with the family. Sometimes we'll ultimately pursue more of a modified version of the screening, so maybe doing ultrasound every 6 to 12 months instead of every 3 to 4 months. But really the goal is just to make sure that all of the information that a family could possibly need to make an informed decision is presented to them. And then they can make a choice about surveillance that makes the most sense for them, which sometimes changes over time even for a family. But at the very least, we do recommend liver palpation with all physical exams. So that's including our physical exam annually and GI, and then also all of their exams with their primary care physician.
Thank you. So it sounds like a very family and patient-centered approach to screening in younger kids. And that's helpful in terms of kind of thinking of how to take care of these young kids, really based on the family and their needs. Do you notice a trend in terms of how old most children are when they start surveillance?
Yeah, unless there are symptoms, so things like bleeding, pain, changes in bowel habits, most of our families have been willing to wait until the 10 to 12-year age range to start the colon screenings. But FAP doesn't occur in a vacuum, so we do have patients who have other more common GI disorders, so things like celiac disease or IBS, that will warrant doing screenings before we would have started the screening for FAP. So at that point, we'll just start FAP surveillance at the same time if they needed a colonoscopy or endoscopy for another reason. But our GI physician, Dr. Erdman, has always said that in his experience, he feels like GI physicians who have less experience with FAP in the pediatric setting tend to do too much too fast. So maybe doing colonoscopies and endoscopies every 6 months in young children, when really he would space those out to much less frequently. But a lot of it also comes into play, again, going back to family and parental experience with the disease. And sometimes that can be a factor that's driving surveillance expectations as well. So if a family comes in and they're not sleeping at night because they really need to get that surveillance started and just know what's going on, a lot of times that will be a motivation to start it a little bit before that 10 to 12-year age range, whereas a family that's a little bit more relaxed about the diagnosis or more familiar with it might be comfortable waiting. So again, we really kind of individualize it to the family to some extent.
And are children ever doing sigmoidoscopies instead of colonoscopies to start?
We have not done that in our clinic. Dr. Erdman really prefers to, if he's going to do the procedure, to do the full colonoscopy to get a baseline. But we have had families ask about that option, and then typically once they discuss it, families are on board with going forward with the colonoscopy.
Is there a common age when most of your patients have undergone genetic testing?
For us, it seems to be in contrast to this whole theme of waiting until the age of assent, where a child can say, yes, I'm somewhat involved in this conversation and I'm getting close to the age of screening. Most of our parents have wanted to know right away, and this has been true kind of across the board. So whether the referral is due to a family history of FAP or they come in kind of for a seemingly out of the blue finding. So something like chirpy or the freckling in the back of the eye that gets picked up on a routine eye exam, or a dentist who noticed that the child has extra teeth, which can be kind of red flags for FAP. Sometimes we do see a delay for things like issues with insurance coverage for testing. So families may postpone the testing until they can change health insurances or switch to the other parent's health insurance, or potentially even take out a life insurance policy for their child before they proceed with testing. We do have a federal law in place called GINA, or the Genetic Information Non-Discrimination Act, that protects Americans from genetic discrimination in terms of health insurance or employment decisions for most employers. But it doesn't guarantee protection from discrimination from things like life insurance policy decisions or long-term disability insurance. So we do have families who decide we'll take out a life insurance policy for our child before genetic testing so that it's in place in the event of a positive result. And then if the testing is negative, they can cancel the policy. So they're big decisions that a lot of times families don't anticipate having to make for their child at that age, but it is something that we always discuss with the family before we go ahead and order that genetic test.
Certainly, and as parents, we don't generally think about taking out life insurance policies for our children, but in this context, it really seems like an important thing to address.
Absolutely, yeah. We have families who say, "I can do that for my child," so
right.
It's a learning experience for all of us as we go to kind of navigate all these issues.
Yeah, absolutely. Do children or families ever start age-appropriate surveillance while postponing genetic testing for a later age?
We provide this option to our families when we do our initial consultation with them. So we say, you could do the screening and not find out the genetic test result right now, but be managed as if you're positive. But we haven't had anybody make that choice yet in our clinic. I think just in general, a blood test or giving a saliva sample tends to be easier than preparing for a colonoscopy, especially for our young kids. So families usually opt to just go forward with the genetic testing first. We have had a few families that have been referred. We have children from outside institutions who come to us who have been getting screening colonoscopies, either because they had a family history of early onset colon cancer or they had a known family history of FAP, but weren't aware of the genetic testing option, or no one had really offered them genetic testing. And so as we go through records and we're able to get more information, we're ultimately able to offer testing to the children. And sometimes we have found that there are kids who've been getting unnecessary procedures. And, we recognize that in general, providers are just trying to do the best they can by these kids and treat their patients with the resources they have and with what they know. But it's always tough when you realize that genetic testing at an earlier time point could have prevented them from having to go through a more invasive test. So we're always trying to minimize the amount of invasive testing that has to be done if we can.
Many patients with FAP will eventually have a colectomy because the tumor burden becomes too hard to manage. Can you discuss how your team decides on when it's time for surgery?
Yeah, as you know, there are a lot of factors that go into that decision just to go forward with the surgery. And those can be medical, so things like polyps having high-grade dysplasia, new or just ongoing symptoms that are really impacting a young adult or a teenager's quality of life. Sometimes it's a family history of really early cancer progression, and they're just nervous to not go through with the surgery earlier. It can also be personal factors, so things like wanting to get it done before college, or wanting to wait until after a study abroad trip in college, or after a marriage, or wanting to just minimize having to go through so many invasive procedures. So our focus is always just to try to interfere with normal life as little as possible, so both from a surveillance perspective and then ultimately from a surgical perspective. So a lot of our patients actually have surgery more in young adulthood after they've transitioned from our care. So we spend a lot of time talking about that as a major milestone in their care, but a lot of times we're not the ones who are actually providing care to them at that stage in the process.
And your program may follow these children with FAP over the course of their childhood. But as you mentioned, at some point, it's time for them to transition to adult care. Is there a typical age that that transition occurs?
We don't have a specific age necessarily, but it's typically more of a natural transition in life. So that could be leaving for college, moving out of town, getting pregnant for the first time. But usually by the time patients hit 20 to 22 years of age, we really start encouraging them to start exploring options for adult care if that's not something that they've done already. But even from the time we first meet with the family or we first have a new diagnosis of FAP, we always try to help patients think about FAP in the long term. So our GI physician always describes it to families as a marathon, not a sprint, to be diagnosed with FAP and to treat it. So we're always having conversations about our role in a patient and family's care and kind of introducing the idea over time that at some point it's time to transition on to providers who are going to be better equipped to take on their care when they're adults. So we want it to not be a surprise to them that transition is coming, and we don't want any family to feel like they're being forced out before they're ready, but we also want them to have the best providers in place for where they are at that point in life.
So this is something that they're always kind of aware of, but I imagine that they tend to get attached to your team, especially because they start with you so young. What are some of the issues to consider in determining when is the best time to transition?
Yeah, there's so many factors. A lot of them are really specific to an individual patient or family. So since we see patients that come from all over the United States and also we see international patients pretty frequently, our first question is always, is there an adult provider that's even available in their area who has enough experience with FAP that they're going to be comfortable treating them? We do sometimes get patients who come back to our clinic after they have more unsatisfactory experience somewhere in adult care. Often this is not locally, but from farther out. And at that point, we really work hard to find somebody that they connect with who has the expertise they need to take on their care. Locally, we have a really great relationship with our adult GI providers, so we're really fortunate there that we have a reliable option for local patients. But certainly our patients who live in more remote areas, we spend a good deal of time just searching for the best option for them from a GI management perspective, and then also for continued genetic counseling, and if they're getting psychosocial support or if they might need it in the transition, finding somebody for that as well. But it's tough, like you said, because we see these patients through their most formative years. So they really do develop a sense of trust with our team and a sense of comfort in coming to our hospital for their care. This is where they've always come a lot of times, or sometimes they've come from a negative past experience with an outside provider. So they really form an attachment to our clinic as a place where the parents finally got answers, or even the kids had finally somebody who talked to them about their disease. So we try to really make sure that they are educated at every visit about FAP, that they feel really thoroughly educated and empowered so that when they do have to take ownership of their own care, wherever their life takes them, they're able to do that confidently.
In your experience, what has been the toughest or the most challenging part of transitioning to adult care?
I actually asked our team this question recently, and we all had the same answer, which was family involvement, or I guess the lack thereof. So when there's not a supportive family member involved, kind of helping coordinate the patient's care early on, and then when it becomes more appropriate, helping them to take on more independence in managing their care, we see that the transition is just universally a more challenging experience for the patient and for the provider team. So even when there is a strong support system in place, the pediatric setting is just an environment where you're going to have more hand-holding, for lack of a better term. And so it's hard to leave that environment and to take on more responsibility for scheduling your own appointments, for making sure that you're on top of your surveillance and asking for those resources when you need them instead of knowing that they'll be provided automatically. So, leaving the comfort of a familiar pediatric setting is going to be jarring for any patient and family. But we certainly notice this as a much rougher transition if there's no reliable support structure in place. So because of this, we always are encouraging patients early on, identify your support person way before the transition is going to happen. That can be a parent or a sibling, a partner or a spouse. It can be a close friend, but having somebody to help you really navigate that process so that when it comes time to transition and everything else is unfamiliar, you still have that familiar support person in place.
And is there any particular way that you or your team supports their patients and their families during the transition process?
Well, as we were talking about, all of our families do meet with that pediatric psychologist early on, and she's key in kind of helping them get ready for this transition process, and she and I really work together on that. And, like we talked about, FAP really doesn't occur in a vacuum. So just like anyone else, some patients have other challenges going on either an individual level or a family level, and they could be completely unrelated to the fact that they have FAP. So we really work to help work through some of those challenges. Our psychologists will try to identify any opportunities for intervention so that as they're going into that transition process, they've addressed some of the more typical barriers that we talked about to transition. And then they're equipped with strategies for dealing with the stress and anxiety that comes with just transitioning to a new place. And then we also try to make sure they're really well connected to resources. So we have them physically bring in their support person and show us who that person is. But then we also plug them in with things like support groups, either locally or through Facebook or other social media, so that wherever they go, there's some kind of support in place after they leave us.
Great. And so speaking of support, do you have any favorite groups or resources that you share with patients and that you could share with us?
Yeah, for our younger patients, we always use the FAP and Me patient guide that was developed by the National Society of Genetic Counselors. And that is a great tool because it's really specific for kids. It uses really kid-friendly, non-threatening language to help describe just basic genetic concepts, ideas around diagnosis, and even what the surveillance is like for FAP. So we've had families who say that their kids actually bring that book into school, both the patients and their unaffected siblings, and they'll use it to kind of talk about FAP and to give words to what this is and why they sometimes miss school for screenings or things like that. We're also big fans of the Hereditary Colon Cancer Takes Guts Foundation that was founded by Travis and Shawnee Bray. And a lot of our families have actually connected with other patients through this meetup group or through their meetup groups that they have available. And then we here at Nationwide Children's have a Connecting Families resource that lets us introduce families with the same conditions being treated in our hospital. And then they can kind of provide mentorship and support for each other as they're at different points in the process. So some of our teenagers take a training session so that they can then become mentors for younger patients who are maybe just being diagnosed or just starting to experience more problems or starting surveillance for the first time with FAP, so they can kind of support and lean on each other. And I think our mentors get something out of that, and our mentees get a lot out of that as well. And then outside of that, our families have been incredible at making us aware of other support groups that have emerged either through social media or just other people that they've met at conferences or things like that. So we've been able to connect patients to these groups just by way of learning about them through other past patients, which has been incredible.
Right, well, this is an amazing list of resources that you're able to offer. I think that's all the time we have today, actually. Kristin, I want to thank you so much for speaking with us and sharing your expertise.
Absolutely. Thank you so much for having me.
Thank you. This is the last episode in this podcast series, and I want to thank our listeners and encourage you to stay tuned for more future podcasts and educational resources brought to you by CGA and the Education Committee.